We're happy to be here and joining this group to talk as much as we can in this short time about the need for suicide prevention, which I think has only grown, and then talk a little bit about screening, identification, and risk assessment. So I'll really, in all likelihood, be providing, hopefully a little bit of an entree into this work, because there's specific trainings on each of these elements that can go into a lot more depth than we'll be able to in the start of here. So Carrie, can I get a thumbs up if we're seeing my screen? Okay, awesome, wonderful. So yeah, I love this echo model in general, and hopefully we can all learn from each other moving forward. So I will get right into this and talk about why we're doing this important work, if I can. Okay, so clearly there's an urgency behind early detection. We're seeing this youth suicide as a major public health issue. Encounters for suicidal ideation and attempts at U.S. children's hospitals have doubled, really in the past decade. We've also seen that those rates at children's in Ohio kind of follow these national trends. We see different age groups, including very young kids, increasing at a pretty significant rate. And we know that we need to start this work early. We know that we need to identify kids before they have years and years of struggling with suicidal thoughts, depression, anxiety, and a range of issues that the kids are showing. We also know that the school years typically introduces a range of stressors. This past year has been really hard to sort of predict because kids are at home, but they also have a number of increases in risk factors due to the pandemic and isolation. But we still won't know any of those recent numbers for some time now. So we kind of want to avoid the sensationalism of, like, if kids aren't in school, horrific things will happen. We know things are very stressful right now for our kids. We are seeing increased rates of depression, anxiety, and different suicide attempt indicators, but that data won't be clear for a little while. We certainly know that over time, this is not a new issue. This is not a pandemic specific issue. Suicide rates have been going up in the United States for quite some time, with actually that rate increasing in the past decade. We know that 10 to 14-year-old suicide rates have tripled, and we know that young girls are even more at risk as well. We also know that Black and Indigenous youth are at high risk as well, and we need, I think, specialized support for identification and services and culturally responsive approaches to each of these groups. Again, I won't kind of bombard you with stats because we have some other topics to cover, but we think in all cases, maybe preaching to the choir here, but that suicidal ideation should always be taken seriously. It's a prevalent, although it's prevalent, it's also a significant marker of emotional distress. We've got millions of individuals who experience this per year, so it's certainly a major issue. In high school, we see 19% of individuals in the most recent 2019 Youth Risk Behavior Survey seriously consider suicide. 16% nearly have made a specific plan, and 9% have made a suicide attempt in the last 12 months. This is anonymous reporting, so there's not specific motivation for a young person to make up this detail, and it's really consistent year to year. So it's not if there's a issue in our schools or in our primary care practices or in our communities, it's where do we identify those who are most at risk? How can we help, and how can we build pathways of care that are responsive to the needs that we're seeing? And we also know that young people are not receiving the treatment that is warranted. And we also know that access to care is an issue. So lots going on here, but we certainly know that screening in healthcare settings should be a priority. The majority of individuals who have died by suicide have had contact with a medical professional prior to death. We also know that youth will disclose when asked directly at a pretty high rate. But we need to do better at training our staff and making sure everyone's prepared to do this work well. We know that screening is increasingly acceptable to many parents and teens in healthcare settings, certainly in our mental health care settings, and it's consistent with a lot of our other screening. So it requires a clear follow-up process and consultation. There are barriers for sure, time and resources. We need to have good pathways. We need to have good training across all of the core elements of suicide screening and risk identification and safety planning, which I'll talk about. We want to understand that sort of there's lots of motivation for patients not disclosing suicide risk, such as shame and embarrassment, cultural values that suggest talking about mental health is not acceptable, fear of repercussions, these things. So it's really up to us, the providers and mental health care providers and professionals, to set the stage and to help shift the actual environments of where we're asking these questions, that we're not making the system so hard to navigate that it takes these Herculean efforts for a young person at risk to have their needs made known to others. And then we need to make sure that those who are there can sit in empathetic, curious, and effective ways of asking these questions directly and be more comfortable. We know our training, especially mental health, is not adequate for the most part in a lot of our graduate programs. We know that physicians aren't given the skills that they need, and that the comfort level of both medical providers and mental health clinicians and community providers isn't near what it has to be. So we have to do a lot of work up front before we start building these pathways as well. And so we'll talk about different ways that we've tried to do that. So at Nationwide Children's Hospital, we embarked on this zero suicide effort, which I won't get into the details, but I will provide a resource for those of you who want to get into that. Our goal is to understand where we do well and where we fail to meet the needs of our community, and where our medical system and mental health care system can be improved. So we identified several core processes that we think will shore up that pathway, and we want to make sure that we use good screening instruments to increase identification. So we use the Ask Suicide Screening Questions, or the ASQ. Other systems use the Columbia Screener, which is certainly something that could work well with some systems. And within our behavioral health system, we ask any youth age 10 or up at our diagnostic intake, and then monthly. These 4 questions that show up on the ask that I'll show you, and then we've found that most of the research suggests you can use the ASQ in a targeted way when there may be some indication of increased risk for age 8 and up. And a lot of primary carers and folks that don't have behavioral health identified as a need, 12 and up is often an age range that's used for universal screening. And then when there's any positive screening, you want to have a clear pathway for how that screen is follow up. It's definitely not advisable to have a positive screen that's just floating out there and eventually is addressed by a practice. So we want to have a clear way of getting that information from the negative or positive screen to the next step, preferably a warm handoff to the risk assessment. The risk assessment is a deeper dive into suicide risk. So we looked at, again, a lot of different options, and the following are a couple of really good options if there has been a positive suicide screen, and the Columbia Suicide Severity Rating Scale, and the actual brief suicide safety assessment, which is part of the ASQ toolkit that you can access freely on the NIMH website. Is something that a lot of people use, and that's also a good option. And then a safety plan, which we'll get into, but those are pretty standard across the board. And we just, with young people, we want to think about their school environment involving their caregivers and several other factors. Here's that. If you really want to get into a deep dive about zero suicide in a pediatric healthcare setting, we did a webinar with the Children's Hospital of Philadelphia, maybe about, well, I guess I see the date. It's about 6 months ago, I think, or 7 months ago. And that is a nice way to look at why we chose what we did, how we integrated the medical record, how you can think about workflows beyond the scope of what we're talking about here today. So I just wanted to let you know that exists. And and I'll get into screening here, just a few of the principles that you can think about. As we know that screening is really that really brief upfront way of determining, could this individual be at heightened risk? And then the risk assessment, if that's positive, yes, let's take a look at this individual in a little bit of a deeper dive, look at it can be something that looks at all the thoughts, feelings, behaviors, and pieces that could lead us to believe that, yes, we can confirm this risk and we need to estimate the imminent risk and then guide our next steps. In the interest of time, I'm just going to let you know that a lot of these scripts can be found on the NIMH ASQ Toolkit website, which I could provide to Kara afterwards. You can Google NIMH ASQ and you'll get it right away. But the goal here, I just want to highlight that we need to share with the families why we're doing this and what we're doing. So we would sort of talk about the idea that the best way to screen a young person is sort of directly asking them questions and doing that in private, because there are some demand characteristics if you have a parent in the room. If they insist on being in the room, then we allow them to stay in the room and move forward. It's still better to ask those questions. And so we also know that it's important for there to be a clear workflow. So after we give the parents information about what it is we're going to be doing, then we would ask them a series of questions. And then we'd ask, for example, these very clear, direct questions. This is the ASQ. And if I could pull that up, what you'll see here, I just want to highlight, these are very concrete questions written at a grade level of about 3.5, so that people can respond very clearly to thoughts about suicide. There's lots of measures out there, including the PHQ-9, that have very fuzzy language around hurting yourself and all that. The ASQ is very direct about someone wishing they were dead, or have you had thoughts about killing yourself. So it's helpful in that we're getting right to the core issue that we want to assess. This is a really good suicide risk screener. The psychometrics are really good. So I would recommend, if you're working with youth, that this be a consideration. And one thing I will add, a lot of folks have a practice of screening for depression or anxiety, and if that's elevated, screening for suicide risk. I will tell you, the data is really clear. If you do that, you will miss individuals who are at risk for suicide. You'll miss about 25 to 30% of individuals, because not all kids who are depressed or anxious, or not all individuals who are at heightened risk for suicide are also depressed or anxious. So just something that is worth noting. Also worth noting, if a person doesn't respond, then it's more likely that that they are more consistent with being at heightened risk for suicide than not. So a no response is equivalent to a yes in the way that we screen. If any of the first 4 questions are positive, then you would ask the 5th question, which verbatim is, are you having thoughts of killing yourself right now? And that imminent risk typically involves a warm handoff to a person who can assess that risk. For us, within our system, anyone who answers yes to any suicide specific question is going to get a safety plan. So I know if I'm going to have any attempt to get through this information, I will not go through the workflows that need to happen. I'm happy to answer any questions like that, but we do have some sample workflows about how these handoffs can occur. That is a critical feature of implementing this in your practice. Documentation is also key at every step of the way. The more your system can make it easy for documentation to occur, like we built it straight into our electronic medical record into Epic, it is very helpful to prompt clinicians. But we want to know what was said, who was notified, and that risk assessment and safety plan are going to occur. So when do we do that deeper dive of a risk assessment? When are we going to actually sort of get a sense of whether there's risk that needs to really be actionable here? So if there's, again, for us, any of those positive questions 1 through 5, we're going to typically do a risk assessment. And if we also follow up with questions, whether there's been, even if it says, has there been suicidal thoughts in the past few weeks, we really do follow up, and we would consider wanting to do a risk assessment, even if those thoughts have been within the last few months. Why I say that is because among all individuals, but especially among youth, suicidal ideation, suicide risk is a pretty unstable type of thing, and it's hard to predict. So if we have indicators that it's been fairly recent, and this person's never had a safety plan or never had their risk assessed at a lifetime level, it's really a good time to do that. So we really sort of, if anything, over respond a little bit to get a sense of where they are, so we can leave with a good sense of that young person's safety. And again, we wouldn't want to have an acute positive safety issue and not respond in the moment, or with a clear way to follow up. So again, any good risk assessment is going to assess risk and protective factors, the thoughts, plans, intent, access to lethal means, and screening, and using that screening data as a starting point. We want to develop a collaborative safety plan, working closely with that youth and family. Again, I would highly recommend going digging into an entire safety plan training, if that's not something you've had the chance to do, and then using that clinical judgment as to what that person's past history would look like, and then certainly document. Here is that brief suicide safety assessment that we're not going to go over, but knowing that that's a resource for you all to draw from, again, on that NIMH toolkit website. And then I will tell you briefly what we use at Children's, which is the Columbia Suicide Severity Rating Scale lifetime pediatric version. I know that's a mouthful, but they've got lots of different versions. We use the pediatric one because its language is a lower level and it's a little bit less dense, but it still allows to access all the main categories that we find are important. There's a nice evidence base behind it. It's a structured tool. We can build it into our medical record, and it really gets into all the ideation and behavior that I think are really important. And here are the main areas for the thoughts, or the ideation, which, again, if you break it down into two parts, we're going to look at all the thoughts, then we're going to look at all the potential behaviors. The thoughts would be ranging from very passive, wish to be dead, and then you start to add layers of specificity as you get towards the higher risk elements. So non-specific active thoughts. So the person isn't just wondering about being dead, they actually feel like killing themselves makes sense. And then killing themselves with a certain method in mind, but without intent to act. And then once you have intention to act, the risk of suicide increases substantially. All of these elements are important, but you start to your risk at 4 and 5. Having a specific plan with intent is something that often leads to a higher level of care in those situations. So there's so much good stuff to talk about, not enough time, but we get into ideation. We also talk about the intensity of the ideation, the frequency, severity, and in the kids version, it's just about frequency in this case. Also, you always want to assess behavior with kids, especially in all cases, but with kids, you often have kids who have had do not endorse any thoughts of suicide, but have had very significant behaviors, or have had times where they've acted out on either aborted attempts or made attempts, but they're telling you, no, I haven't thought about it, because kids move from either these very quick acting ideas, and we're really sometimes talking about minutes between that initial suicidal thought and action, which is why supervision and reduced access to lethal means is so important. But with the behavior, we're looking at previous attempts, non-suicidal self-injury, and then whether they've made preparatory action. And then in our case, if there's been an attempt, you might look at lethality as well. There are some good resources and trainings. We have a training that we do within the community at no cost on suicide risk assessment and safety planning specifically, which is like a 3-hour training. So what I'm going through here is not going to meet those needs. So I'll just make a last point, because I do want to stick to time and allow for a rich discussion here. But I will say safety planning is it's part of a good risk assessment, but it's also an intervention that is an incredibly important suicide reduction tool. And so it should never, ever be this throwaway kind of at the end, after visit summary kind of a tool that you print out a list, do X, Y, and Z, and you're good to go. A really good safety plan is one of our best tools for reducing suicide risk among young people. It should be done collaboratively in concert with that young person's needs. It is not a no suicide contract, which in the old days was used, to have a young person agree that they won't kill themselves. No evidence for that. Signing something doesn't help you resolve any of your liability. We're seeking a defined commitment to safety with tools that a young person is willing to use. And if they're not willing to engage in that process, or they have no confidence, that they're showing you no confidence that they'll use these skills, that may be an indicator that a higher level of care is necessary, or that their risk is going to be increased over time. And that's done in both, you'll look at that through physical and emotional components when you're evaluating that. Um, and really that safety plan is only as good as the actual agreement that you have with the young person. So you don't need to fill it out just to fill it out. If that person has tools that work for them, you're going to explore that in a lot of depth. Make sure it's accessible, that they have all the tools at their disposal, and that pieces of paper are less effective usually than what they're carrying with them. Whether it could be a laminated card, could be a cell phone app if they have access to that, and that they need this information at their fingertips when they're in a crisis. We need to assume that we're not going to be able to predict the crisis very effectively. So we need to give them the tools to understand when they're going into crisis and what they can do effectively to mobilize their environment to get support when they need it. So here's a couple of apps. I will unfortunately stop there because I'm like over time already, and I'm very happy to ask questions unless Kara tells me differently. I will kind of just leave you with a couple of take-home messages on the screen so we can get chatting. It goes fast. I'm sorry. I'm trying to do.
Oh yeah, no, thank you very much, Dr. Ackerman. This was wonderful, and we do recognize the difficulty in trying to push forward so much valuable information in such a short period of time. We have all been challenged by that in the ECHO format. But this is a great introduction and certainly whets our appetite for more. And I'm sure we'll be asking you to come back. So thank you very much. Very helpful and meaningful to every one of us, actually, in the jobs we do on a weekly, daily basis.